evening, my friends. Today is Wednesday, September 16th. My distinguished, world-famous, world-renowned guest this evening is Dr. Svetlana Blitzstein. Dr. Blitzstein is a neurologist specializing in autonomic nervous system disorders. My old job, she is the director and founder of the Dysautonomia Clinic. She also serves as the clinical assistant professor of neurology at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences. Dr. Blitzstein completed her neurology training at the Mayo Clinic Graduate School of Medicine and received her MD from the University at Buffalo School of Medicine, where she received numerous awards for academic achievement. She graduated from the University at Buffalo Honors College with a Bachelor of Science in Biochemistry, summa cum laude, where she was the valedictorian of her graduating class. And if I were going to place some money on who the smartest person on this call is, my bet's on Dr. Blitzstein. Welcome to the show, Dr. Blitzstein. Thank you so much for being here.
Thank you for the vote of confidence.
Absolutely, absolutely. So our team here tonight is many COVID long haulers. And we, as you know, we have this sort of mixed bag of symptoms. And what I would love is if you could start us off by talking a little bit about what your experience and observations have been so far with respect to COVID-19.
Okay, so thank you for inviting me this evening to speak on dysautonomia and how it relates to COVID-19. I'm a neurologist who specializes in autonomic disorders. The autonomic nervous system is the part of your nervous system that controls important function in the body, like blood pressure, heart rate, digestion, urination, and blood flow. The autonomic nervous system is essential to the health and disease. It's how we adapt to external environment, how we maintain a state of balance under various conditions in the environment, and how we process any type of physical or psychological stress. When the autonomic nervous system malfunctions, a person can develop a number of symptoms and signs that result in a disorder. There are many autonomic disorders out there. I mean, thick textbooks have been written on the topic of autonomic disorders, some of which are common and some are rare. But we will concentrate today on the most common ones, like postural orthostatic tachycardia syndrome, neurocardiogenic syncope, or NCS, and orthostatic hypotension. So how does all of this relate to COVID? Well, the most common trigger of POTS is a viral infection, which includes viruses like influenza, Epstein-Barr virus, enterovirus, parvovirus, and others. So post-viral dysautonomia is actually quite common and what I frequently see in my clinic. With respect to COVID-19, when it appeared in the United States in early March, reports of some patients taking a long time to recover were coming in from China, South Korea, and Japan. So I have anticipated that post-COVID dysautonomia may be a long-term complication of that virus, just like it can be a complication from other viral infections. We also knew from SARS outbreak in 2002 that almost 50% of patients with SARS had lingering symptoms compatible with chronic fatigue syndrome. So it's not surprising at all that SARS-CoV-2 or coronavirus, a virus related to previous SARS virus, is causing a post-viral syndrome as well. So I have seen a number of patients with post-COVID dysautonomia or long COVID. These patients that I had are young people in their 20s, 30s, and 40s who were either healthy or had minor medical problems that didn't affect their functional status in the past. And now after having COVID-19, they're experiencing severe fatigue, tachycardia, shortness of breath, dizziness, headaches, numbness, digestive system and symptoms, and inability to exercise or return to work. Some are able to work at their previous jobs, some have to go part-time, and some are unable to work at all, even from home. So right now there are no specialists in long COVID. I know everyone wants to see that elusive specialist, but none of us are, because long-term effects and complications of this virus haven't been studied yet. We're all learning. The CDC says that 35% of patients who had COVID-19 did not fully recover 2 to 3 weeks after having the virus. And at least 20% of these were young people who were supposed to be well on their feet in a couple of weeks. So it would be important to determine through research whether long haulers have abnormal tilt table tests, which is what we're going to discuss today, and other tests of the autonomic nervous system. I need to mention it now, and will probably mention later, that there is one study from Germany that used cardiac MRI on patients with post-COVID symptoms, and there was evidence of heart muscle inflammation or myocarditis in 60% of patients who had it like 2-3 months before. And almost 80% had abnormal MRI findings consistent with some type of cardiac inflammation. And we also just recently had a study from the United States. The study was of athletes in Ohio. Almost 50% of these patients had abnormal cardiac MRI, and 15% had evidence of myocarditis or heart muscle inflammation. And these patients had mild symptoms, and the 2 patients who had myocarditis had actually no acute COVID symptoms, were asymptomatic. And so we have this, very puzzling, intriguing, unusual presentation from this virus that can cause anything from severe acute illness with people being in the hospital on ventilators to being actually very asymptomatic, yet still resulting in serious complications long term. And now we have researchers from Mount Sinai saying that they estimate that approximately 70,000 of New Yorkers may be long haulers. So that's a large number. And I think many physicians, including neurologists and cardiologists and primary care physicians, would have to become very familiar with these patients and would have to become very familiar with dysautonomia in general. So that they can go through proper diagnostic and treatment decision making. Of course, an important step in this diagnostic process is going to be to stop labeling these patients with anxiety, depression, or stress, and instead, to do the proper diagnostic workup for these post-viral conditions. So I'll stop now just so that we can go further and kind of talk about more distinctly about certain things.
So when we talk about dysautonomia, is that an umbrella term, or is that a diagnosis? Because a lot of people are kind of saying, okay, this is attributed to dysautonomia, but if we look around this Hollywood squares of 50 people, dysautonomia seems to show itself differently in each person.
Sure. So dysautonomia, it simply means abnormal autonomic nervous system. And it's synonymous with autonomic dysfunction of any kind. It's not a diagnosis, and it's simply a descriptive term. Kind of like we say headache, but we don't specify, because the term headache doesn't specify what type of headache, why you're having a headache. Is it a brain tumor headache, or is it a migraine headache, or is it a meningitis kind of headache? So I'd like to mention, it's very important when we say dysautonomia and autonomic nervous system that we understand that we're talking about 3 parts of it: sympathetic, parasympathetic, and enteric nervous system. And each of these 3 systems can malfunction, resulting in specific syndromes and disorders.
Would you mind just taking a moment to just talk about each one and what it does? So sympathetic, parasympathetic, and enteric?
Sure. So, the entire autonomic nervous system is your output system. What does that mean? Well, the inputs, the sensations, everything we, feel, think, even, or experience externally in the environment need to be processed by the nervous system, by the peripheral nervous system up to the central. The central simply means brain and the spinal cord. And the peripheral nervous system is all of the nerve roots and nerves and a very complex network of peripheral nervous system that we have. And the autonomic nervous system is an integral part. It consists of central autonomic networks. They're in the brain. They're in the brain stem. They're modulated by the hypothalamus, amygdala parts of the brain, insular cortex. Things are quite complex there. And then from down, the messages to the body are transmitted through the spinal cord. And they come out through the peripheral nervous system, the autonomic nerves. Probably the most famous nerve that you guys have heard about is the vagus nerve, right? That's the one that everyone heard about. And it is a very important part of the parasympathetic nervous system because it controls the output information to everything: heart, lungs, digestive system, bladder, everything. And then we have the parasympathetic nervous system that is coming out from the spinal column out to the ganglia, out to the sympathetic chains, and that controls all of the bodily functions. Your pupillary size, your heart rate, your blood pressure, digestion, urination, everything is controlled by these two systems. And enteric is in your digestive system. So you can see how, all three parts are important in dysautonomia. But in what we're going to talk about today, the post-viral types, or POTS, neurocatagenic syncope, and orthostatic hypotension, it appears that there is a sympathetic overactivity and parasympathetic sort of imbalance in POTS. That's very important, sympathetic overactivity. What does that mean? It means that the sympathetic nervous system, for some reason, is in overdrive. And that creates imbalance because the body likes to be in the balance. Parasympathetic with sympathetic with enteric. But there is a constant activation of the sympathetic nervous system, which creates all of these, problematic symptoms. Mm-hmm. Can you hear me? Okay, I think people can hear me. Okay, so the sympathetic overactivity, this overactive sympathetic nervous system, creates these very bothersome symptoms. Your heart rate is up, right? Your blood pressure may be up, but could be down.
Lost you again for a second. Sorry, doctor.
Okay, is that better?
Yes.
Okay. So I left off as the sympathetic overactivity creates these symptoms. Your heart rate is up, your blood pressure is likely up, but could also be low. Your respiration may be up. It feels like anxiety, except that a lot of the times patients would say, I don't feel anxious at all. I was just watching TV. I was just sitting in my room. I was just standing quietly. And then the symptoms just go. Sympathetic overactivity, you feel hot, you feel sweaty. Maybe you want to go to the bathroom. Maybe you want to urinate. Maybe there is a bowel movement. That kind of a hyperactivation of the system. So that's part of the symptomatology, of course.
And, here's a question that I often wonder about. So I see things like I'll watch a patient and I'll see their heart rate cycle from 80 to 90 up to 140 and then back down to 120 and 80 and sometimes into the 50s. My question is this something that's although very uncomfortable, is it something dangerous and potentially lethal for somebody? So how worried do we have to be about that?
Okay, so the first thing, of course, when we have a patient like what you're describing, you watch their heart rate goes up. Is it going up? You ask yourself, is this heart rate in elevation happening when they stand up, just with the simple act of standing? And if yes, then we have evidence, we have preliminary evidence of orthostatic tachycardia. That's abnormal. Because normally what happens when you stand up and about almost a half a liter of your blood goes down to your lower body, your leg, your pelvis, you start to pull. Normally, the mechanisms are in place to get this blood back up to the heart and to the brain. And that's very quick responses from the barrier reflexes, from the vascular system, everything vasoconstrict, the heart receives enough blood back and distributes it to the brain. That's normal. And the heart rate elevation normally is about 10 to 15 beats per minute. And it stabilizes the blood pressure. The patient feels no symptoms and they're just standing there like they're not doing much. You don't think about these things because the autonomic nervous system is an automatic nervous system. You don't have to think about it. It'll just happen normally as part of the body. In POTS patients, this does not happen. The mechanisms are faulty. And so when you stand up with POTS, blood will go down. The mechanisms will kick in, but in order to keep that brain perfusion or blood flow to the brain going, the heart rate will go up excessively by at least 30 beats per minute is the definition or one of the objective criteria of POTS. So now you're standing there, your heart is racing, like you said, it's 140 beats per minute. Now, in some cases, there are patients who wouldn't be aware that that's happening. In some cases, but in most cases, of course, if your heart rate is 140 standing, that's a definition for sinus tachycardia. You will feel this activation, adrenaline rush. Maybe you're becoming lightheaded, dizzy, nauseous, dimming of vision. You start to feel like you're gonna pass out. But here is the funny part. This is almost a good thing that your heart rate is compensating. That's a good thing. That's what's keeping you up. Because if the blood is low and the heart rate does not go up, you can't stand up. So it's a abnormality. It's a physiologically abnormal response, but it's also physiologically appropriate response because without that, you can't stand. This is what happens in orthostatic hypotension, another autonomic disorder that's quite common. And in those cases, your blood pressure drops and the heart rate doesn't go up that much, maybe 10, 15 beats per minute. It doesn't compensate enough for that low blood pressure. This is what's called neurogenic orthostatic hypotension. There is a different kind of hypotension, orthostatic hypotension, non-neurogenic. It's, you know, when you were sick and you were vomiting and you lost volume, or if you took a medication and it dropped your pressure, there is a drop in blood pressure, but there is heart rate elevation appropriately trying to compensate. That's called non-neurogenic orthostatic hypotension. So right here, we reviewed, you know, common autonomic disorders, 3 of them at least.
So if I'm understanding you correctly, the mechanism is that somebody stands up, their position changes, blood drops down, right? Pressure drops first, lack of venous return. Is that what causes the heart rate to race, or is the heart rate racing on its own and that's what leads to the other things?
So the second criteria for POTS is that blood pressure does not change. That's a second criteria. The first one is heart rate elevation by at least 30 beats per minute or greater than 120 from supine to standing in an adult. In teenagers, the criteria is 40 beats per minute elevation. It's higher. The second criteria is blood pressure does not change. Actually, POTS is viewed as a disorder that doesn't involve blood pressure drop. It's not a disorder of orthostatic hypotension. It's a disorder of orthostatic intolerance, but not hypotension. And the third criteria, you need to have symptoms of orthostatic intolerance for 6 months. In earlier criteria, there was a suggestion of 3 months. Usually we want to see 6 months. It's a chronic disorder of orthostatic intolerance. And I think it's probably what many of you are experiencing after COVID, that you find it's difficult to stand or exercise or go to the store. You feel better when you sit down or lie down. And that's chronic orthostatic intolerance. The symptoms specifically that patients report are the number one across the board is dizziness. Dizziness upon standing. That's very important. Those are the symptoms. The second one is fatigue upon standing. You're feeling weak, kind of fatigue, generalized weakness, like you're gonna fall over. That's very common. Of course, palpitations. If your heart is racing, you're gonna feel it in your chest. Some people have chest pain. Some people have shortness of breath. Some people have severe nausea. And yet other people feel abdominal pain. Very interestingly, abdominal pain that's positional is very suggestive of POTS or another orthostatic intolerance disorder. Dyspnea, heavy legs. People will say, wow, my legs feel heavy when I walk, like they're lead. And then when I rest, I feel better. That's another clue. There are clues that we teach, young doctors, residents, and, nurses and other doctors in primary care, how to spot. How do you spot? Because patients don't always come to you saying, I have orthostatic intolerance. That doesn't happen. They come with complaints. It's up to us. It's up to physicians to figure out what exactly is going on. Where is this fatigue coming from? Or they would come with headaches and they would say, my headaches are bad. As soon as I lie down, I feel better. Always positional change, positional symptoms is a big clue to us that we might be dealing with orthostatic intolerance. There is one other category that I want to mention for older patients. Older patients may have a different presentation than young patients. When they have orthostatic intolerance, they may not even feel symptoms of OI, orthostatic intolerance. What they may experience are falls, right? It's not an uncommon presentation that, well, I fall, or I lose my balance, or I stumble. And again, it's up to us in neurology especially, but also in primary care, to figure out what does that mean? Do you have weakness in the legs? So let's go check with neurologic exam. Do you have problems in your cerebellum because you're unsteady? So is there a problem coming in from the back of your brain, a part called cerebellum? Or is there orthostatic intolerance, dizziness, that you're on your feet walking, shopping, and all of a sudden you feel like you're about to fall over? Is it coming from there? So I want to make that distinction, because by age group, people will present differently. There is no one size fits all.
So this is an oxymoron right here, but I'm going to say for the typical COVID long hauler, which we know there's no such thing as a typical COVID long hauler, when they have this standing up and this leg fatigue, is it to their advantage to kind of go with the symptom and sit and rest, or do we try to overcome that gently and try to rehab people by starting to move them a little bit more?
Okay, so very important question. A lot, at least in my clinic, the patients I see are younger patients with post-COVID dysautonomia. And we teach everyone that if you feel dizzy, like you're gonna pass out, number one thing to do, you have to sit down or lie down with your feet up. You don't go challenge your body, because that means you can end up on the floor, and we don't want that. Right? So if you feel dizzy, lightheaded, like you're about to fall over, there is no need to challenge yourself. You got to sit down or lie down with your feet up, drink like you're doing right now, drink a glass of Gatorade or water, wait for this to pass. Because one other form we did not talk about is neurocardiogenic syncope. And that's a different form than POTS or orthostatic hypotension. That's a common form when all of a sudden you feel like you're going to pass out, and you do. And on a tilt table test or a stand test, what happens is you drop your blood pressure by more than 20/10 change within the first 3 minutes of a tilt. That's one of the requirements. Now, what happens when you drop your pressure and your heart rate? There is nothing that keeps the blood flow going to the brain. So that's a prelude to a syncope. People pass out, lose consciousness, they fall over, which actually is a good thing because that restores blood flow to the brain. You wake up, you're conscious. Unlike a seizure, you know what's going on. You're not confused. You're like, wow, what just happened? Well, you lost consciousness, you passed out. That's another common form, neurocardiogenic syncope. Now, a lot of you probably did pass out because just a simple syncope is so common. It affects like 15 to 20% of all teenagers or all young people. That's one of the most common reasons for ER presentation is just a simple syncope. That's not a big problem. If you pass out occasionally, that's fine. The problem becomes, of course, when you pass out recurrently or you feel lightheaded on your feet or dizzy, like you're gonna pass out every time you stand up. So there should be a distinction. Just recurrent syncope once in a while, that's fine, or frequent recurrent disabling syncope that affects your functioning state.
I saw a study recently about teenagers where it said the most passing out was related to beer and wine coolers. Have you seen that one? That was in Milwaukee. Anyway, so my next question to you is this. Can you talk a little bit about, so in my opinion as a rehab specialist, so we want to get people moving, okay? My experience is that for many patients, 2 minutes, awesome. 3 minutes, awesome. 3 minutes, 15 seconds, boom. It's like the car has flooded and the engine has flooded. Can we talk about the role of compression stockings and leggings, abdominal binders, salt and electrolytes, and how should we be using these and what should we be using and how?
Okay, so every time I have a patient with dysautonomia, we go through treatment options. We always start with non-pharmacologic approach first, right? Regardless of what's going on, whether you are on 1 medication or 10 medications or none, we always want you to implement non-pharmacologic approach because it can help. And as you mentioned, there are compression stockings and abdominal binders that are simply designed to vasoconstrict, to constrict your lower body, to get the blood back up to the heart and to the brain. There are different kinds. So the ones we typically recommend are the strongest compression, 40 to 60 millimeters of mercury, which is kind of, tight. They are very tight. And we recommend compressions up to your waist. So not knee highs, not thigh highs, up to your waist. Abdominal binders can be very helpful, especially when you pull blood in your abdomen and pelvis, which does happen quite often. Sometimes patients try compression stockings, they feel like they're not helping. And when they try abdominal binders, that helps more. It depends. Now, the problem with these compression stockings, it depends where you live. If you live in Florida, you might be having problems wearing these heavy, tight things on you because it's hot. If you live where I am, now with the fall weather, it's going to be okay. So they might be tough to put on as well. And they could be, uncomfortable. So sometimes I tell my patients, buy very tight tights, those shapers that women know what I'm talking about, buy them very tight tights, try them out, see how that is. Yes, they're not medical grade, but it could help a little bit. And when people say, well, none of the compression stockings have worked, I'm just gonna wear knee highs. You know what? I never say no. It's so benign. I say, hey, that's fine. Whatever works. They may not work, but if you feel like you need to wear them, do wear them. So that's how I approach this. There are lesser grade. There is 20 to 30 millimeters of mercury, and there's 40 to 60, and you can be fitted for them at a medical supply store. So if you have insurance and your cardiologist, neurologist, primary care doctor prescribes 2 pairs, oftentimes insurance would cover 2 pairs, medical grade, and you can be fitted properly for them because everyone is a different size.
So your preference is go right to the waist high.
Yes, yes, because they also compress the pelvis, everything. You know, if you compress it up to your knee, that doesn't mean much. Everything is accumulating in your veins and arteries above the knee.
And then how often and when and for how long should people be wearing these? Because I get a lot of people who say, well, you know, I'll wear them today, I won't wear them tomorrow. My understanding of how we retrain the autonomic nervous system is with consistency. Is that right?
Well, everything is, you know, we wish it was like black and white. I wish I could come on here and give you like an excellent case control study that actually showed how great. None of it is like that in the field of dysautonomia. As in most medicine, you know, we're dealing with not black and white things, but all shades of gray. So this is how I approach this, you know, with years of experience and, you know, hundreds of patients with dysautonomia. I ask, does this work? Did you feel like they help? And if they say, yeah, I think a little bit, great. Then you should wear them when you wake up until you go to bed. You take them off at bedtime and wear them every day. But if they say, I tried it, nothing, I say, fine with me. You don't need to wear them. You don't need to. Everything is symptomatic. I try to go by how the patient feels, because I feel like that's even more important than the vital signs, because as probably a lot of you know, you may have good vital signs. Your heart rate is good because you're taking a beta blocker. Your blood pressure is good because you're drinking fluids and eating salt. Maybe you take a Midodrine. Everything looks good, but you feel very, very sick. And people and doctors and cardiologists, especially because they want to hang, you know, they want to use these vital signs. Like, what do you mean you feel sick? Your heart rate is 90 right. When you're standing, your blood pressure is 120/8. That's perfect, because it's not about blood pressure and heart rate. There is also cerebral perfusion. That's a very important concept. Cerebral perfusion, because what's going on here at the arm when the doctor takes your vital signs doesn't mean that that's what's going on in your brain. We know that patients with spots on the tilt table test have lower oxygen levels as measured by cerebral oximetry. We have the tools in research than patients who are healthy. And similarly, we also know hypoperfusion is happening from Doppler studies and all other kinds of studies. And just recently, there was a great study from Hopkins, from the colleagues whom I know. They took patients with spots and patients with chronic fatigue syndrome and patients without POTS, but with chronic fatigue syndrome. And they identify cerebral hypoperfusion, even if you have no evidence of POTS, even if you have normal tilt table tests. That's a very important concept that I think a lot of doctors miss, because they want to fix these vital signs and they feel once I fix your vital signs, you should be right. Fine. That does not happen. There is.
Well, you're the first person who mentioned that. That's the first time I've heard that mentioned in all discussions of COVID. Now, how do you measure cerebral perfusion?
That's a very important question. There is no easy tool. Like if you ask me today, I cannot send a patient to get cerebral perfusion. Now, I can get certain scans like MRI perfusion with certain exotic sequences, but insurance is not going to pay for this, exotic testing. I can do Dopplers to measure velocities, transcranial Dopplers, we have that. And so a lot of these tools are in research that involves cerebral blood flow. There are many PhDs in the country working on this specific topic, cerebral blood flow. There are research labs and researchers who do that. On clinical level, we don't know. We assume, when you tell me that you have brain fog, you have fatigue, you have headaches, you can't concentrate, I need to assume that we're dealing with symptoms of cerebral hypoperfusion. Even if your blood pressure and heart rate are just fine, and even if your pulse ox is 99, 98, you still feel pretty bad, because pulse ox over here on the finger is not the same as oxygenation of your brain tissues. There is abnormal physiology there, abnormal physiology that we're just beginning to understand. We used to view ME/CFS as, years ago, people thought, well, it was psychosomatic, then we moved on to maybe it's metabolic, right? Maybe it's mitochondria. Then we moved on, well, the cardiovascular system is not coping. The 2-day exercise test that is done in certain labs in the country is showing that that patients with ME/CFS are not doing well on the second day. So there is that. And now I think rightfully so, we moved, and that doesn't mean they were wrong. No, they were right. But now we moved on to brain. Is there evidence of neuroinflammation? And we have preliminary evidence that yes, there is evidence of neuroinflammation, some evidence preliminary. And if there is evidence of neuroinflammation, maybe at brainstem level, it's obvious that there is going to be, sympathetic overactivity coming from the brainstem, not from the peripheral nervous system. These are all new concepts, and not everyone is on board. New things are very hard to implement. There is dogma in science, right? We used to think of POTS as just heart rate and blood pressure, so if you don't have a heart rate elevation or blood pressure change, how can you have POTS symptoms? Well, people have them. So I think the research is moving in absolutely the right direction in ME/CFS and dysautonomia fields, that now we're getting a bigger picture. Is a very complex picture that we cannot just put labels with heart rate, blood pressure, or diagnostic criteria for ME/CSF, where we say, well, you've had this fatigue for 6 months, you've had an autonomic dysfunction, and the tilt table test showing autonomic dysfunction is actually one of the minor criteria from the CDC when they updated it in 2017. So autonomic dysfunction is very important to these syndromes of fatigue. Whether it's,
I'm sorry.
Yeah, go ahead.
Yeah. So we've seen a number of POTS patients over the years, and we've seen a lot of pulmonary hypertension patients who often have similar exercise response where they stand up, heart rate spikes. We often bathe the system in oxygen. We use high flow oxygen during exercise. Do you think that's something that would be beneficial in this situation with COVID? I'm sorry.
COVID, we need to kind of step away from everything I was discussing on dysautonomia and now talk about COVID, because we don't yet know what this COVID dysautonomia is. And we have to do research. We have to identify, are these patients fairly the same as my post-influenza dysautonomia, or are they different? Because they may not be the same. On the outside, it looks to us that, of course, symptomatology is similar. There is the fatigue and tachycardia and shortness of breath and exercise intolerance and brain fog. It appears similar, but we need to objectively prove that they're similar to the other patients, or are they different? That's why I talked about cardiac MRI. It's a very interesting and a great tool that I believe should be accessible to not only athletes. And not only research studies in US or Germany, I hope it becomes available to patients. And insurance needs to pay for it because it's an expensive study. And so in terms of that, when we scan patients with post-COVID symptoms, we already have evidence that there is quite significant inflammatory abnormalities there at the heart level. I'll tell you for sure that there are zero studies that took patients with dysautonomia or ME/CFS in the past and identified anything similar. Zero studies. Now, what does this tell me? I don't know. It tells me that we don't know what all other dysautonomia patients are, because do they have the same evidence of inflammation? Is it coming from the heart? Is it why we see tachycardia and chest pain and a lot of cardiac symptoms? Or is it completely different? For example, if the dysautonomia patients are showing normal cardiac MRI, and it's only COVID patients that show inflammation at the heart level. So while we want to lump them together, scientifically, we're not there yet.
Do you have a sense, and I know that the answer to so many questions about COVID is we don't know, but do you have a sense of progression or how much better people can expect to get over time?
Yeah, it's a very important question. Because what's the prognosis? You know, we kind of concentrated on acute COVID and for people to survive acute phases, and we call it success because the death rate, mortality is lower now. But we haven't even begun to understand what are the long-term implications. So I'll give you what we know from dysautonomia. You know, the first study that came out on POTS in early 90s, late 80s, painted a very rosy picture of POTS patients. And they said, you know, 2 to 3 years out, 80% are doing really well. Great. And so we went by that study. And when I started practicing in the community, I didn't see those numbers, okay? I didn't see them, my colleagues didn't see them, and thankfully the study was updated to give us a more realistic picture of what happens to patients with POTS. And what we know is that only less than 20%, 19%, felt that they were recovered, normal, so to speak, at an average of 5 years out. 50% felt that they're better than they were 5 years before, and then some people felt worse. That's the more realistic picture. There are improvement, you know, there are worsening, and they're, you know, staying the same or better. This is for the regular dysautonomia. Now, when we go with post-COVID dysautonomia, of course, there is no data. What we know is that some patients have symptoms 6 months, and probably some of them are here. Now, personally, the patients I have, they are getting better. Of course, they tend to be younger people, motivated, that have found me and they want to get better, and they have great testing and good treatment and good doctors. They're getting better. Some patients are back to work full time, and they just have residual symptoms of, usually that's fatigue and exercise intolerance. It's much harder to get past. And some people are still struggling. But personally, in my clinic, I do not have horrible disasters. That I can say. Patients that I have are milder and are getting better with treatment for dysautonomia.
So we've spoken about the fact that many of the long haulers are younger. Many of the long haulers are people who were told stay home and didn't get treatment, and really, in many cases, by the grace of God, survived, you know, at home alone. Do you have a feeling that had these patients, and I'm not looking to point, you know, fingers or shift or create any blame, but do you have the sense that if many of these patients were treated right off the bat, that a lot of these long haul symptoms might have been avoided?
You know, we want to think that way. Wouldn't it be nice if we said, well, if I do everything right, then the outcomes are going to be great. And the real honest answer is this is a very, I think it's a very unique virus because, as I mentioned before, not only it can cause severe acute illness, it can create a very bad post-viral illness when the viral illness was very minimal, like a runny nose or something minor. We know from some case reports and case series that some young people who had stroke, they tested positive for COVID. They never even had acute viral illness with runny nose or upper respiratory disorder. So, and similarly, young athletes may have very little or nothing, and yet suddenly, they have all these complications. So it's a very difficult, nasty virus that we need to, investigate. I think it causes a vascular kind of picture, a vasculopathy. I think it causes prothrombotic state. It can cause not only immune alteration, but autoimmune disorders. At least 50% of patients with COVID test positive for antiphospholipid antibodies. That's very important finding. These are antibodies that increase your risk of clots, blood clots in the legs, blood clots in the lungs, and that's an important finding. So we see this being sort of a virus that perhaps affects the endothelium. The endothelium is the inner layer of blood vessels, and creates this vasculopathy type of disorder that manifests in different ways in different people. I think it's going to be important to decide genotypes. What genotype, what kind of genetic differences are there in population that makes one person react to the virus as if, not much is happening acutely or long-term. Some people end up with cytokine storm, as you know, and then others, looks like more young people, end up with not much, and yet long COVID. I've had one young woman who never had any respiratory symptoms. She was always healthy, nothing respiratory, suddenly severe fatigue, can't keep her eyes open, hypersomnolence, difficulty going to the store when previously she had none of those. So that's the kind of issue. So I'm saying that this virus is very mysterious and not like other viruses.
Very insidious, yes. One of my friends described it as COVID will find your weaknesses and exploit them. So do you think that much of what we're seeing is that COVID is causing, and again, I know this is a kind of a we don't necessarily know answer, but I'm curious about your opinion. Do you think that that COVID is causing many of these conditions, or do you think that COVID is kind of unmasking conditions that may have already been there, or both?
It's a hard question to answer because the virus itself can be a big trigger because people test negatively. Supposedly, the body cleared the virus. That's what we assume. We haven't figured that portion out. But we assume that if you test negatively, then there is no virus in the body actively, at least not in the serum, at least not in the nasal mucosa that we test. But what happens after that, it appears to trigger a cascade of events in the realm of immune, autoimmune, prothrombotic pathways. And when you say, well, is it unmasking? I'm not sure, because I've had long COVID patients who I just had her last week. She had the flu before and all of the other viruses that kids brought in. And she's never been sick that way. But with this round, she got sick. Her kids are better. Her family members are better. But she's the only one who hasn't recovered. So it's very hard to say. I think right now, I have a couple of patients who had some kind of, abnormality in the autonomic nervous system before. For example, they were predisposed to fainting, right? For example, or they were predisposed to dizziness, but they function great. And now with post-viral trigger, now they're facing severe symptoms. So that's an important point. And some people just walk around feeling healthy. Maybe they have some asthma. Asthma is very common in the US. Maybe they have some allergies, and they consider themselves healthy. But when a stress in the form of coronavirus comes in, suddenly, as you said, perhaps it unmasks, perhaps it worsens the underlying predisposition that they may have had. So this is an area we just need to explore better. For example, there was a short case series out from Europe where they took 4 young and healthy male who ended up on ventilators. I think 2 of them were brothers, 2 were unrelated, and they did genotyping. And they found that all 4 of them had a problem on an X chromosome, a deletion in certain area. Now, could this be a marker? Are there others going, among us, healthy people with some genetic abnormalities on X chromosome or other, or, HLA type, what controls your immune responses? We don't know, but that would be the area to figure out.
Thank you. You mentioned before the compression garments, and you just briefly mentioned Gatorade. Are there other things that you like? Is Gatorade your electrolyte of choice? It's got a lot of sugar. Are there other things you recommend, and also salt tablets?
Yeah, I mentioned Gatorade as one of the options. But when I was starting to talk about non-pharmacologic measures, binders and compression stockings is just one part. Mainstream is we recommend that people consume at least 2 to 3 liters of fluids per day. Everyone with dysautonomia, 2 to 3 liters of fluids. Now, if you live in Florida and you're out walking around and it's 95 degrees, you're gonna have to increase that consumption of fluids. And the fluids it's not water. A lot of my patients say, I drink a lot of water, it's healthy. It is healthy, but it's not going to stay in your body because we're not made of water.
Exactly.
We're made of physiologic solution that contains sodium and chloride and potassium and all other things. So if you drink a lot of water, you're going to end up urinate that out. That's just how the body is. And funny part about water is that you can drink so much that you're actually going to wash out important electrolytes. So don't drink a lot of water, but drink electrolyte solutions, and that can include water and maybe a salt tablet. Okay, so the other thing we recommend is consuming at least 5 to 7 grams of salt, depending on your blood pressure. So if you're, 20 years old, your blood pressure is fine, consume at least 7 grams of sodium chloride salt per day. That's a lot of salt. And as I always explain to patients, the American diet is very hard to get that. So I recommend that patients get salt tablets. Okay, and they come in different shapes and forms. Some of them are enteric-coated, so you don't feel nauseous from them, but you can take a salt tablet and it's gonna have 450 milligrams of salt, of sodium chloride in it. The tablet is called Thermotabs. I have no ownership, I have no stocks in the company, but those are simple, easy, and cheap. And
what is it called? I'm sorry?
Thermotabs. Thermotabs. Yeah, that's one kind. There are others. There is a sodium chloride 1 gram. There are potassiums. There are non-tablets. I don't want people to think that, this is my preference. Absolutely not. But as an example, if you take Thermotab, 450 milligrams of salt in 1 tablet, and let's say you drink, maybe 10 to 12 ounces of water, that's a good bolus, oral bolus. So you're giving yourself an oral saline bolus, okay? And when you do this acutely, we actually have studies to show that you acutely raise your blood volume, acutely decrease your heart rate, and maybe decrease dizziness, and maybe it will allow you to sit more, walk around more, and not feel dizzy like you're gonna pass out, and buying you some time. So that's an important point, fluids and salt. The fluids can be an electrolyte solution. Some people throw in some salt in it, you know, but who can drink salty water? It's very hard. Some people throw salt and sugar and maybe add a little lemon and drink this throughout the day. So you want to drink an electrolyte solution and not simply water. And you want to increase the intake of salt through your diet, salty snacks like pretzels, like pickles, right? You want to eat that. That increases your salt intake. A very important point, if you're an older person and if you're running a blood pressure of 130/80 or 135 borderline or 140, your requirement is going to be different. Now, you're still going to have the intake of salt, but it's not going to be 5 grams. It's not going to be 7 grams. It's going to be more like 2 to 3 grams. You know, years ago, there was a movement, no salt, zero salt diet, the way to go. And then suddenly there were studies that showed that even patients with hypertension need some salt in their diet. So salt is not your enemy. The amount is going to differ.
Do you have a specific number of French fries you recommend per day with that salt?
Zero.
No fries?
No.
Okay,
no,
gotcha,
zero.
gotcha. Couple of other questions. So a lot of people report this kind of vibration within their body. What on earth is that?
So it can be different things. I'm a neurologist, not only specializing in dysautonomia, I'm also a neurologist in general neurology. And it's for us in neurology, it's going to be very important if we see this vibration. Some people say, I have tremors. So I'm going to test to see if you actually have tremor. If I see you have no visible objective tremor on my exam, then as you said, we're going to call it internal tremors or shakes. What can it be? It can be many, many things. But in our dysautonomia patients, a lot of the times it means low blood volume. You got to load yourself. It can mean also sympathetic overactivity, just like you said. Just like I said previously, that the sympathetic nervous system is going to activate your heart rate, blood pressure. You will feel hot, you will feel sweaty, and you feel this internal shakes as in fight and flight response. So this internal shake can be different things. And I need to specify that importantly, you want to rule out electrolyte abnormalities, like your sodium, potassium, calcium need to be on the level. Okay, and once we rule out anything bad, your blood work is normal, which is common in our patients, then I say we got to increase fluid intake, because a lot of patients feel when they load themselves on fluids, all of the symptoms get better.
So when you say low fluid, so I assume you're talking about low plasma volume. What's actually moving? Are they feeling the fluid because there's more space for it to move around?
No, you can't feel.
I mean, so what's moving? What is that sensation? That's what I don't get.
Yes, it's a sensation of internal, right? It's you know, when you feel nervous and you feel butterfly and you feel like you're shaking inside, but nobody can see it. This is the part of sympathetic nervous system response. It's a sensation that is part of the, you know, autonomic disorder, the symptomatology. It's a sensation.
That probably is what was going on. I saw this old lady the other day that swallowed a fly. No, I'm just joking. Just kidding. So another question: what is with that in mind, with the vibration? What is the relationship to lying down and sleep? Because a lot of people are awakened by this.
Okay, so we need to define what we're talking about. So this sensation, internal vibration, it's important that you go to your neurologist with this complaint, and that your neurologist goes through the proper workup. And it's going to include your electrolytes, and it's going to also include vitamin levels. Very common things are common. So we don't want to say, well, it's COVID. You know, a lot of the times I hear doctors say, well, it's your dysautonomia. We can't do that.
Exactly.
Okay?
Right.
We need to be sure what we're dealing with, because we don't want to miss things. So your neurologist is going to do an exam, just like I said. You're going to do this, you're going to do that. We need to see if there is visible tremor that we see. And if we don't see it, we also do a very important exam, sensory exam, right? I have to check your sensations in your feet to see if you have decreased sensations of coldness or vibration or touch. If I see that there is objective evidence that your sensations are decreased, I have to do a proper workup. And it's going to be your vitamin deficiencies. It's going to be, you know, your blood glucose level. Let's not forget, very high blood glucose level, as in diabetes, and very low blood glucose level, as in hypoglycemia, are going to be important with this, what you describe, vibration sensation. So I got to go through proper workup before I say, well, looks like I didn't find any identifiable cause on the blood work. Your B12 looks good, your B6 looks good, you're not diabetic, you're not dehydrated, your electrolytes look good, this is not essential tremor, this is not Parkinson. And then I can say, probably this is part of your dysautonomia. And you mentioned sleep. Now, for people to sleep, they have to have very normal mechanisms in place. Your brain stem, your cardiovascular, and importantly, your autonomic nervous system. And in the evening, normally, the parasympathetic nervous system is going to be dominating. The sympathetic nervous system is going to be down, because in the evening you come, and with diurnal variations in your brain and your cortisols and your melatonin levels and your epinephrine and norepinephrine, the picture is going to be set for you to sleep. What happens in dysautonomia? As I said, sympathetic overactivity. So you're going to try to go to sleep with this sympathetic overactivity. It's not going to be surprising that there is going to be sleep disturbance, right? Because there is a hyperactivation of sympathetic nervous system. So people will be jolted from sleep, as you mentioned, or they will say, or they will have weird, vivid, scary dreams. Their heart rate will go up abnormally. They will have frequent awakenings. And the sleep will become unrefreshed, which is what happens in patients with dysautonomia, chronic fatigue syndrome, fibromyalgia, you name it. So again, it's a spectrum of sympathetic overactivity. And what I want to do as a doctor, I want to decrease that sympathetic overactivity with medications and non-medication treatment options that we just discussed: fluid, salt, compression stockings, deep breathing, everything that slows down your heart rate, your breathing, everything that enhances parasympathetic nervous system, and everything that decreases sympathetic nervous system. That's what you want to do before bedtime to improve your sleep patterns. Sleep disturbance is very, very bothersome and important to our disorders.
Is there any specific one breathing pattern that you recommend over others to quiet the sympathetic nervous system?
There are studies on that. There was actually a recent study showing that actually pulmonary therapy or breathing exercise can improve certain subset of POTS patients. And again, this is not my area, so you probably can tell us the patterns, but it's the kind of pattern that decreases sympathetic nervous system and increases the parasympathetic nervous system. It's the kind of breathing they also teach you if you have anxiety and panic attacks.
Gotcha.
It's the breathing from your abdomen. It's the kind of breathing that is done in meditation and yoga.
I have two more questions, and then I'm going to go to questions from the audience. And Beth, if we could open up the chat now for questions as well, if people want to type. I would like to know about the relationship. Many women report a worsening of symptoms around menstruation. Can you talk about that for a little bit?
Sure. So in dysautonomia, there is a big area of hormonal influence. What we know about POTS specifically is that 80% of our patients are young women of childbearing age, from age 15 to age 50, but patients who are older and younger are there as well. There is a huge hormonal component, just by the fact alone that our patients are young women. Another fact is the common onset. The age of onset is usually around 14 years old. The age of onset typically correlates with the age of menarche, okay? So there is that hormonal influence. Another thing we know is that one of the other triggers, we said POTS is triggered by a virus, whether it's flu or parvovirus or coronavirus. Another trigger is pregnancy. Pregnancy is a common trigger. Postpartum onset of POTS is common. And yet another subset of patients that I sometimes see are women in their perimenopausal or almost menopausal age who start having hot flashes and things like that, and they develop dysautonomia later on in life. So there is a big component. And another interesting thing there is that studies are showing that men do better with dysautonomia than women. Not surprisingly, I see that in my patients. The men with dysautonomia, I see they're still able to exercise some and still able to work. They're not as disabled, because we know that in men, the autonomic nervous system is just stronger. There are biological differences. And so that's a big trigger. If you have periods that are coming on, then worsening of dysautonomia symptoms right before your period, this is very common, which is why quite a few of our young patients go on birth control to suppress menses and not lose that.
And what about the relationship with autoimmune diseases? I know it's kind of very new, and we could probably talk about that for a year, but in 30 seconds or less.
Well, I can start with that my study was the first one demonstrating in a cohort of 100 patients with spots that there was a higher prevalence of autoimmune markers and autoimmune disorders in patients with spots than in general population. We start there. Obviously there is this connection, and then we move from there. Now we move to more specific antibodies that are being discovered as part of POTS and as part of dysautonomia in general. That's what we need to research. You know, a hypothesis that I have is coronavirus causing an autoimmune response where the body now is producing antibodies possibly to the adrenergic receptors, alpha, beta. We know that this is happening in dysautonomia patients not connected to COVID. So is COVID a trigger of antibody formation then binds to receptors on the cardiovascular or autonomic system and causes this post-viral dysautonomia? In other words, is post-viral dysautonomia an autoimmune disorder? We're getting there, but we're not exactly there.
Gotcha. Could you talk a little bit about body temperature regulation? So ever since the outdoor weather turned significantly cooler, I've been unable to stay warm. It's still 60 degrees, but I feel like it's much colder, and I'm often shivering with intense goosebumps. Is this related to dysautonomia, and is there anything I could do about it?
Yes. So temperature dysregulation is one of the features of all autonomic disorders, because the autonomic nervous system controls how your body regulates temperature. we have autonomic function tests, and one of them is a test called QSART, which is a quantitative pseudomotor action. Pseudomotor means sweat response. And we know that in patients with spots, at least 50% do not produce these adequate QSART responses. Okay, so there is a difference in sweat. A lot of times people feel like they lost the ability to sweat properly. If you're not going to have the nerve endings that allow you to sweat properly, as in small fiber neuropathy, you're going to feel overheated all the time. And heat intolerance is one of the features of POTS and dysautonomia. Some people have cold intolerance. They can't get warm even if it's 100 degrees out. This is all part of the same circuit that's abnormal in controlling your response to different temperatures. So it's best to be in cool environment. Avoid extreme heat and avoid extreme cold.
You had mentioned you'd mentioned non-pharmacologic treatment of POTS. Can you talk about some of the medications or the pharmacologic treatments?
Sure. So blood volume is a very important concept. Hypovolemia is at play in dysautonomia. To this end, we use blood volume expanders. One of them is Florinef. Fludrocortisone is what your body naturally produces and helps your kidneys conserve sodium and water. Fludrocortisone is not a big steroid. It's a weak mineralocorticoid that we use, and there have been studies to show that it helps. We also have vasoconstrictors. You know how we said blood goes down and it's not coming up? Well, part of it is because the vessels are not vasoconstricting properly, both veins and arteries. So we have midodrine, which is alpha-1 vasoconstrictor. It vasoconstricts your receptors and it allows blood to move up to the heart and the brain. Another very important first line category are beta blockers. Beta blockers are excellent. They're going to slow down your heart rate and they're going to decrease your sympathetic overactivity. We use a couple of beta blockers. One is propranolol, which is a beta 1, beta 2 blocker that goes to the brain and helps the brain to come down, so to speak. We use it. It's FDA approved for migraine prevention. And we use another one, atenolol, which is more cardioselective, which goes straight to the heart to decrease heart rate and sympathetic overactivity that way. I want to mention that beta blockers are used also for social anxiety, public speaking. So it can also help with these internal vibration you're speaking of. I use them in my patients. So talk to your doctor. A low dose of a beta blocker can just get rid of them. And it's not the benzodiazepine, which is, has addictive potential. I try not to use them too much or frequently. So beta blockers are very, very important. We also have a medication called Mestinon. It's a medication that increases acetylcholine and kind of enhances this parasympathetic nervous system action. And that's a very good medication as well, Mestinon. Then we have other medications. We have stimulants that I use if patients feel, very fatigued. There is brain fog. They have to study for an exam or they have to work. Maybe we use a low dose of stimulant like ADHD drugs, like Adderall, Ritalin. Maybe I'll use Provigil or Nuvigil for patients with severe hypersomnolence who can't keep their eyes open. We also have antidepressants that I don't jump to, but they have a role. Some patients will respond to antidepressants. And we have a medication that was FDA approved for orthostatic hypotension called droxidopa that improves your blood pressure. that way. We also have a medication that's not beta blocker that can slow down your heart rate called ivabradine. Ivabradine is newer in the US, but it's an old drug from Europe, and it slows down your heart rate, but it's not a beta blocker because some patients do not tolerate beta blockers. And I think I want to mention very importantly that there are also other therapies like, for example, immunotherapy that's coming out for autonomic disorders that has immunologic basis, like IVIG, like subcutaneous IgG. Those are expensive immunotherapy drugs that have a place in patients with dysautonomia and comorbid autoimmune disorders. There are also exercise protocols that have been shown to help. There is an exercise protocol from Texas that is very intense that some people can engage in and can, you know, improve significantly to the point that they no longer meet criteria for POTS. We also have IV saline. We can use it sometimes for treatment refractory cases. We use intravenous saline. So we have a bunch of things. You just need to know how to use it because, you know, there is a lot going on. Number one comorbidity in POTS are headaches, migraine headache. And so we have to treat headaches. If a patient has uncontrolled headaches, it's going to make their dysautonomia worse. And if they have dysautonomia, it's going to make their headaches worse. So we have to address both comorbidities. I address neuropathic pain, numbness and tingling. If there is, I should mention this because there is a lot of talk about it, mast cell activation syndrome. We haven't talked about. It can be comorbid. About 20% of patients with spots, at least 20% have a mast cell disorder. Mast cell may be also a substrate for post-COVID dysautonomia and even for acute cytokine storms. There is talk about that. So when a patient feels that they're suddenly allergic to everything, they suddenly can't tolerate food that they used to eat or environment, they have rashes, they have a lot of GI symptoms, they have itching, respiratory symptoms, I test them for mast cell activation syndrome and I treat them. When I treat them with antihistamines and they improve, I know that there may be mast cell activation syndrome in my dysautonomia patients.
Okay, I'm going to ask you a question and then we're going to go to the speed round, okay? But the question I have, and I'm sure a lot of people have the same question, is you just mentioned tonight about 200 things that I've never heard before in the context of this conversation.
Yeah.
And people have difficulty even sometimes getting a referral to the most basic specialist. That's like an oxymoron, basic spec. But like some people can't even get to a neurologist. What do you recommend to people who are saying, yes, like I see people, it's like, I feel like if this were a church, people would be saying amen. But the idea is, how do we get this treatment? How do we get this evaluation?
So there is a big problem in healthcare. You know, it's hard to see a specialist. And when you see a specialist, these issues that we're talking about, you know, dysautonomia, post-viral syndromes, for a long time, it has been considered not to be mainstream neurology. And it has been considered not to be mainstream immunology. And cardiologists felt that it's really not up their alley because it has nothing to do with heart. The heart in dysautonomia is usually fine. That may be different in post-COVID dysautonomia, or that may change if we scan regularly. I don't know yet. But most basic cardiovascular tests, echo, stress test, EKG, Holter monitor, it shows no problems with the heart and no evidence of cardiac arrhythmia. The sinus tachycardia is not a cardiac arrhythmia in their world. And the infectious disease doctors used to say, No, there is no evidence of virus or infection or Lyme disease, right? Post-Lyme syndrome, we're talking about always 10 to 20% of patients who couldn't recover. Where do these patients go? And so in this field of autonomic disorders that used to be a rarity, I think now is becoming more mainstream. People want to learn about autonomic disorders. You know, years ago, nobody cared that much about POTS. And now look, you know, we're talking about post-COVID dysautonomia. It's mentioned, you know, on CNN, in different articles. We have great nonprofit organizations that have done great things research-wise, awareness-wise. So some of us have been in this field, but as you mentioned, it's certainly not enough. So I always hope that, you know, primary care physicians and my colleagues in neurology and our colleagues in immunology and allergy and rheumatology and even cardiologists can now become sort of, you know, experts on dysautonomia, because everyone is going to be seeing patients with post-COVID symptoms. Everyone is going to be seeing patients. And when they read about dysautonomia and when they listen to webinars like that, they're going to get ideas and clues. What do I do? Where do I go with this? There are 50 symptoms right now, right? The patient is not getting better. EKG is good. Chest X-ray is good. Blood work is good. What do I do? And I say, if first identify clinically, is there evidence of orthostatic intolerance, right? Is there clinical evidence? Send them for a tilt table test. They're available. And if you don't have access to a tilt table test, do a simple, easy, cheap, what we call poor man's tilt table test in your clinic. Lie them down for, you know, for 5 minutes, check heart rate, blood pressure, stand them up, let them stand for a few minutes and check blood pressure and heart rate in the increments of 3 minutes until 10 minutes. Write down the values that you get and write down the symptoms that they experience. Here's your diagnosis of POTS, easy. You know, in the social distancing time right now, I ask my patients when I do video or phone consults, by video, I ask them to do that in front of me. They slap on the blood pressure cuff and they stand there. It's a self-administered stand test. It works, it's accurate, there is your diagnosis.
I have a sheet that we use, which I will make available to people, which is exactly what you just said, and we'll send this out in an email so that people can, you know, measure their heart rate, blood pressure, oxygen, and symptoms as well. I would like to again go back to a few questions speed round. I'm going to ask you, if possible, only yes, no, maybe so, or I don't know. Okay, so. When I had active COVID, I had a lot of salty chicken bouillon broth, which was helpful and easy to tolerate. Yes, no, or maybe so? Chicken broth.
Yes, yes.
Okay. I had an echocardiogram that showed no heart inflammation. Could an MRI show something different?
Yes, if you can get cardiac MRI, get it. It's hard to get it.
Okay, this one you could answer normally because this is important. How do you treat the nausea and GI symptoms, and how do you treat the vertigo and bad headaches? That's so common.
Yes, that's very common. And as I always joke, unfortunately or fortunately, I had to also become part of the, you know, partly a GI doctor, partly a sleep disorders doctor, partly a psychiatrist, partly a cardiologist, and partly an immunologist. But what I will say to that is, first, we got to be sure that the symptoms can be attributed to dysautonomia. So I always send them to a GI doctor, rule out the usual GI conditions, and use dysautonomia only as an explanation when there is no other more common explanation involved. That way, I don't get to miss ulcers, I don't get to miss, you know, gallbladder problems, and I don't get to miss celiac disease. right? So you gotta make sure that your nausea is not due to GI pathology. And when your GI doctor goes through the workup and says, I can't find anything wrong, of course, they want to use PPIs and stuff like that. And well, it could be your dysautonomia. We treat dysautonomia. We treat dysautonomia with fluid, salt, small frequent meals to avoid hypoglycemia. That's another important point we did not have time to discuss, is that if you have dysautonomia, you don't want to be going, for hours and hours without any oral intake. You got to keep your blood glucose level, because our patients are sensitive, not only to dehydration, but also to hypoglycemia. So you want to treat underlying POTS or neurocardiogenic syncope or orthostatic hypotension. And then if the nausea is still happening, we can talk about your Zofran and some other things that people use for nausea.
Are there treatments related to autonomic caused shortness of breath?
Similarly, and especially in the time of the pandemic from coronavirus, you first want to see your pulmonologist. Visit your pulmonologist, get the pulmonary function test done, get your oxygen checked, get your cardiac echo to make sure there is no fluid around the heart. Do all of that before you come to me and say, oh, my doctor said, I'm short of breath before dysautonomia. I need to know that it's not your asthma or, your post-COVID lung scarring or anything like that. If it is due to dysautonomia, shortness of breath is one of the symptoms. And some patients have that predominantly. They don't have much tachycardia. They're just very short of breath. It may be rooted in how you breathe. Hyperventilation is sometimes a problem in our patients. Hyperventilation. You don't even know you're doing it. But remember, the sympathetic nervous system not only increases your heart rate, it increases your rate of breathing. So you don't even know it, but you might be over breathing, creating this, low state for, and your pH goes up. So that's very important. That's very important. Once again, you want to correct hypovolemia. If you're low on volume, you'll have worse shortness of breath. You want to take your medications, maybe a beta blocker that paradoxically, right? Because some doctors don't want to use beta blockers. They're afraid it's going to make the asthma worse. Quite the contrary, what I see in my patients with controlled asthma. If you give them a low dose of a beta blocker, their breathing gets better, not worse. It's only then when there is acute asthma flare-up and that you don't want to use propranolol that's non-cardia selective. Beta blockers are important as well. You want to use beta blocker over Xanax. Some people, they come to me, they're already on Xanax or Ativan or Valium, and it's helping them, of course, because benzodiazepines also decrease sympathetic overactivity. But I would rather you take a beta blocker at the right dose, the right kind. Don't be discouraged if your doctor gave you a metoprolol 25 milligrams twice a day, like they give to heart patients or hypertensive patients, and you felt very bad. That doesn't mean you can't take it. It just means the dose was too high, or it was not the right kind of beta blocker for you.
So there's a few more questions, but I know we're short of time. I'm gonna give you one more that's a really important question. Chest pain. So many patients experience chest pain or discomfort of various types. And I always talk about the idea that there's what we thought pre-COVID and what we have to find out post-COVID.
Yeah.
Is there a possible neurologic link for chest pain? Like once your cardiac system has been ruled out, is there a neurologic aspect to this?
I'm glad you make that important point that in the COVID era, you absolutely need to make sure that your heart is fine, whatever that means. Does that mean heart is fine? Right now, we're identifying that cardiac MRI tells us otherwise. But let's assume that all of the cardiac tests are negative. Let's assume that your troponin isn't showing heart damage, your BNP, everything is negative. Yes, chest pain can be from dysautonomia. I have those patients. You also got to make sure that it's not costochondritis, obviously, because a lot of young women will have this pain right here. And they call it chest pain, but obviously it's musculoskeletal. You also need to be sure that it's not GERD. You can have this burning pain, discomfort. But let's assume none of it is true. The patient doesn't have any conditions. Yes, you can have chest pain from dysautonomia. And there again, just like all other symptoms, hydration,
Fluids,
salt,
yep.
fluid, beta blockers can be very helpful. Beta blockers, sometimes you need to use calcium channel block. Sometimes we do use it.
Really? Okay.
Yeah. Sometimes.
And what's the mechanism, though? What's the mechanism that a calcium channel blocker is going to work on that?
Maybe vasospastic, maybe. But calcium channel blocker relaxes the blood vessels and also slows down the heart rate as well.
I'm glad you said all of these things over the last 90 minutes, because if you didn't, I was going to say the exact same things.
Sure.
But I want to say, first of all, thank you so much. This was not only fascinating, like beyond belief. I'm calling your office tomorrow to book you again in like 2 weeks or as soon as we can get,
Okay.
because I don't think I don't mean any disrespect to anybody who we've ever had before, and I don't think I'm speaking out of school when I say I think you're the smartest person I've ever spoken to. You've just really, I mean, you've just really illuminated so many things that are not even remotely in the conversation of the 1,000 conversations I've heard about COVID so far. So thank you so much. I mean, really, I feel chills, chest pain, lightheaded, dizzy, all from this webinar. And I mean,
That's
I really—
the Red Bull that you're drinking.
It's probably the Red Bull. But I mean, this was fascinating. And we're going to get this transcribed and we're going to make this available to people. And we're going to just give you a list to take to your doctors, because we don't need anybody besides you. I just want to unmute everybody so that we can properly, Beth, if we could unmute everybody. I don't have that control anymore.
I do not either.
Okay, so we cannot allow participants to rename themselves. All right, anyway, we're gonna do this as interpretive dance. We won't be able to hear it, but everybody, I just wanna say that this was the webinar to end all webinars. So thank you so much.
Thank you very much.
Thank you. You were great.
Wayne and Garth would say, we're not worthy.
Thank you.
Encore.
Thank you. I'm glad to be
This was magnificent.
Thank you very much.
Truly magnificent. Thank you. All right, see you soon. Thank you so much. This was
Thank you.
really
Bye-bye.
super exciting.
Thank you.
Very good.
Thank
Very,
you.
very good.
Thank you, Noah.
Have a great night, everybody.
Thank you. Good night.
Thank you.
Bye.
Thank
After
you.
207 days, it's the best I've heard.
That was fantastic.
Wonderfully incredible.
Wonderful.
Really incredible.
Very informative.
Thank you.
And you said you're only 21 years old, Dr. Blitzstein? How did you do this?
You know what? That supersedes everything. Whatever you said before, I don't care. But this one, yes.
Yes,
This one
yes.
I like.
Thank you so much. That was really the most illuminating information I've gotten. It's like everything I've heard so far put together. So really, thank you so much.
I'm glad it was helpful.
I will see you soon.
Have a good evening.
I think there's going to be a bus caravan to Buffalo soon. So.
Really?
Yes.
Wow.
From
Then
Florida.
how am I
Leaving
gonna
the Zoom.
Then how am I going to do another one of those if I'll be busy taking?
We do it live. We'll do it live. So we'll do it like the carnival. Guess your weight or your age. So
Yeah.
You're gonna guess the dysautonomic symptom. Have a great evening, everybody. Thank you so much for showing up.
Take care.
Thank you.
Thank
Bye-bye.
you, Noah.
Okay.